stepping back from neurology for a second, if in an ideal world you teamed up with a psychologist or psychiatrist and said, if we weren't working in our specialties and we had an ideal way to readjust the diagnosis process, what would you add a little bit of your process and what would you add a little bit of their process? How would you redesign kind of like the way that we think about approaching some of these things to maybe make them a little more efficient?
Yeah, this is great. And we do try to do this a lot. At the university, we have our neuropsychology division is housed in our department, which is helpful because we rely on them a lot. A lot of this comes down to time, and expertise certainly too. So yes, in an ideal world for every patient, we could spend the whole day and we could be doing team interviews. What often happens is we will do our tests. And if our tests are completely negative, then I call up psychiatry and say, something's going on here, something's not right, and then lean on their expertise because they know in detail the phenotypes of how their diseases present, what the natural history is, right? And likewise, that's what they're doing when they will send us a patient and say, something doesn't fit here. I'm afraid this is not primary psychiatric disease. And when they call us up, we will often admit a patient to try to expedite that workup. Same thing. If we call them up and say, I thought at first this was an autoimmune encephalitis, but all the testing's negative. Now, as I'm following, I've seen the patient a couple times. It's evolving. We're seeing less or maybe no inflammatory signal at all. Can you come in and tell me what you think? So in practice, I think this happens a lot more than people might realize, sometimes behind the scenes, sometimes by actually going to different specialists.